I am Dr. Ophtho. I am a PGY1 ophthalmology resident. And for ophthalmology, they require, unlike specialties like anesthesia, dermatology, radiation oncology, radiology, where you just oftentimes do a full year of internal medicine or a different prelim, ophthalmology requires like standardized that you do 3 months of ophthalmology during your intern year. So I'm on my first ophtho rotation of residency. Today's my third day. I'm getting ready to go out. It's about 6:40 a.m. I have to be there at 7:30, but it's a commute. So come along with me. Can't go without the Ocular. No makeup today, unfortunately. I'm gonna go and try and meet my co-residents so we can all commute together. Because we have a session today, this morning, where we're doing tonometry and basically learning how to properly take eye pressure, and there are different ways to do that. No, I don't need to take this with me. Putting that right back there. Okay. Gonna go with my Mayo Clinic socks today. Shout out to them who gave it to me during my interview, I think. Going with my pink New Balances today to match this. For the black people watching, no, I'm not an AKA. I just like the colors. Good morning. I am about to go to one of the other locations. This morning we had a session where we learned how to do applanation, which is a way to check the eye pressure. It was really fun to learn, but definitely have to practice more. I grabbed this coffee and now I'm about to head to the subway to go a bit more uptown to the other location that I'm working at today. I'll be in a Cornea clinic, so I'll let you guys know how it goes. Hey y'all, what's up? Let me put my bag down. What is up, y'all? Let me go somewhere with better lighting. I'm back home. Let's take these off. Okay, good evening, y'all. I am back home from Cornea Clinic. If you don't know what that is, the cornea is at the very front of your eye. So if you were to touch your eye, like right there, you would be touching your cornea. It's like a clear dome. It's not the white part of your eye, but it's a clear dome that goes over top of the iris or the colored part of your eye. So oftentimes if somebody were to poke your eye or you had some sort of trauma towards that front part, you can get some scratches or abrasions to the cornea, and that can cause other issues. The cornea is also very important for refraction, and what that basically means is the way the light bends and lands in the back of your eye. I wish I had a little eye model right now, but I will find a picture. The way it basically works is light shines into your eye and then it passes through your cornea, which is clear, and then you also have something in your eye called the lens that also helps to bend the light or focus the light onto your retina. But something a lot of people don't know is that the cornea is actually responsible for 2/3 of the refractive power of the eye. So oftentimes if you have like dry eyes or some sort of issues with your cornea, because your cornea also needs to be well lubricated, it can really cause issues with your vision. So the cornea and the lens together help to direct the light to the very back of the eye, which is called the retina, and the light signals pass through the optic nerve in the back of your eye, which basically takes the light and visual input or signals from the outside world and carries it to your brain. In the back of your brain is your occipital lobe and the visual cortex. So once the light image goes through your eye to your retina, through the optic nerve, and to your brain in the occipital lobe, you can actually create an image in your brain. And that's essentially what we call vision, right? But yes, clinic was fun. The attending I was working with was nice. And we also had a couple of medical students working with us today, which was really fun. Saw some interesting cases. Did you guys know you can actually transplant the eye, specifically the cornea? Corneal transplants are relatively common actually, and there are different ways you can transplant the cornea. cornea, which I won't get into at this time. But essentially, it's a matter of how many layers of the cornea you're transplanting. Well, I guess I am getting into it. So the cornea, that front window of the eye, has 5 layers within itself, going from outermost to innermost. You start with the epithelium, then you have something called Bowman's layer, and then in the middle you have a big chunk of something called the stroma. The next layer is called Descemet's membrane, and then the final layer is called the endothelium. Endo usually means inside, so it's the layer of cells on the innermost portion. So you can either oftentimes do cornea transplants by transplanting all 5 layers, which is called a penetrating keratoplasty, because you penetrate the entire cornea. But something that I often see more commonly is you can do cornea transplants by only removing thinner portions of the cornea, specifically Descemet's membrane and the endothelium. Those surgeries are called DSEK and DMEK. DSEK is Descemet's stripping endothelial keratoplasty, and DMEK is Descemet membrane endothelial keratoplasty. The difference between DSEK and DMEK is that DSEK, Descemet stripping, takes out the endothelium and Descemet's membrane, but it also takes out a little bit of the stroma, that thicker layer. And then there's DMEK, Descemet membrane endothelial keratoplasty, which does not strip out a portion of the stroma. So that one's only taking the Descemet's membrane and the endothelium and transplanting from a donor tissue. Something I learned today, unlike a lot of transplants where you have to be on a long waiting list, corneal tissue is actually quite abundant. We don't really have a shortage of corneas to transplant. And the type of cornea transplant you do, as well as like the indications, really can vary from patient to patient. But I think I've done enough teaching regarding that so far, just to start. If you want to learn more about it, there's this website called iWiki, EYE Wiki, W-I-K-I, and you can read a lot more about those different procedures. And I will say the penetrating keratoplasties do take quite a bit longer compared to the DSEK and DMEK. I saw a couple post-operative patients seeing how they're doing after getting those procedures done. I also saw somebody who had an infection of the eye from a virus, specifically HSV1, that's herpes simplex virus 1. It's the same virus that causes cold sores. So yes, you actually can get that in your eye. And when it does infect your cornea, it can cause these really interesting looking lesions. We call them like serpentine or dendritic lesions. So it's like snake-like looking. Dendritic meaning branching lesions. And how you're able to see that is really cool. You would take this basically yellowish orange dye and put it in the eye called fluorescein. So it helps light up any defects like in the epithelium, which is, remember, that outermost layer of the cornea. So then when you put on a blue light with the slit lamp, which is the microscope machine that ophthalmologists tend to use, it lights up as bright yellow and you can see any defects in the cornea. I also saw another patient who had something I saw for the very first time today, or even heard of for the very first time today. So I saw something called a decimetocele, or decimetocele. Ocele in medicine usually is talking about like an outpouching in general. So basically what happens, I saw a patient who had some thinning of her cornea in a certain area. I believe the cornea is usually meant to be about 550 microns thick. Let me double check that. Okay, I just double checked. Yes, I was right. 540 to 560 micrometers thick. However, if the cornea starts getting thin in an area, sometimes if you had an ulcer in your cornea and it starts getting damage to those layers, parts of the cornea can get thin. Let's say there's a situation where some of the outer layers got thin or somehow eroded away. What can happen is that if Descemet's layer is still intact, remember the eye always has fluid in it. So because the outermost layers of the cornea have worn away and the thin Descemet's membrane is still there and there's still fluid in the eye, what can happen is that fluid can push through and the Descemet's membrane can bulge and almost form like a little bubble looking thing compared to the surrounding cornea in the area that's unaffected. So I saw a patient who had that today, which is really interesting. hadn't seen that before. I hope you learned something from that, and I hope I explained it clearly. I really try and make things like super simple. And if you're an ophthalmologist or ophthalmology resident and I said something wrong, feel free to clock me, aka correct me if I'm wrong in the comments. But yeah, I think since I have a bit more time, I'm gonna try and get a workout in. I honestly have not been doing the best job with that. You know, we're gonna try and prioritize our health to the best of our abilities. So I'm gonna head to the gym.
Ryan Little.
Japan.
I'm going to add this protein powder. Trying to get my calories up. I lost a lot of weight in the beginning of residency. I'm just going to do 1 scoop, adding some almond milk. And then I'm gonna blend. Okay then. I think there's a problem with this outlet because I tried using this earlier. I really think there's a problem with the outlet here. And I don't know why. It used to work. I'm just trying to make my little smoothie. There's only one outlet in the kitchen and it's not working. So we're taking it to the dining table. Okay. I thought I put a lot more mango than blackberry in here, but it came out purple somehow. This is the drink. And now we gotta transfer this to the drinking container. Okay, let's go. This looks good. Yeah, came out pretty good. Good morning, y'all. It's the next day, Thursday. Got paid today, thank God. Very glad to see the direct deposit hit. I must have put on these little compression socks because today I am on consults. Okay, for the socks, let me put these on. So, these go far. So consults basically means that another medical service, usually the patient's primary team, this is usually a hospitalized patient most of the time, the internal medicine team or whoever the primary team is, it could be the surgery team or something, the team doing the main oversight of that patient's care in the hospital wants to basically request a consultation from another specialty. Let's say the patient all of a sudden says, oh my gosh, I just developed blurry vision, or oh my gosh, my vision just blacked out. If the primary team is concerned, they essentially want to consult a specialist. Most likely they would consult us, ophthalmology. The reason I'm wearing these compression socks is because when you're on consults, it's a lot of walking. Walking to different buildings sometimes, walking around the hospital, and the hospital that I'm in right now is so huge. Like, it is humongous. I think when I was helping it with consults just in the afternoon the other day, I walked like 4 miles that day. Just like randomly. So just so my legs don't hurt. I also like to wear compression socks like if I'm doing some sort of surgical day or even rounding in internal medicine sometimes. Compression socks can be helpful. But literally right now I have to hop on a Zoom call. We're talking about pre-surgical planning for cataract surgery. So I'm excited for this lecture. See y'all soon.
Difference, and they haven't had corneal refractive surgery. Bolero buckle, which can change the axial lens, subtenance, canalog. Ask about if they have CPAP or BiPAP. Because
okay, gonna make some breakfast. These low-key expired a long time ago, a couple weeks. Hopefully they're not chickens by now. Let me Google if it's still safe to eat. Okay, I'm gonna do that test with the water and see if it floats. If it floats, it's bad. If it sinks, I'll take it. Sorry, I don't have any clear bowls to show you guys. Okay, it did sink. We'll take the risk, y'all. I'm too broke to buy new eggs right now. If I die, I hope you all enjoyed the content. This will probably strengthen my immune system. Okay, let me stop making jokes like that actually, because now that I'm a doctor, people are gonna take what I'm saying seriously. Not recommended, by the way. Don't eat expired food if you don't have to. I'm adding these red pepper flakes. This is very Maryland of me, but I'm adding Old Bay. Just a little bit. I'll put in some garlic powder, some black pepper, and you know, I'm feeling fancy. Let's throw in some parsley. Using olive oil. The oil that you use actually can have a lot of impacts on your health actually. For example, I'm Nigerian. Nigerians tend to use a lot of palm oil, but actually that's like one of the most unhealthy oils there is. It has so much saturated fat, which is not good for you. So it's just something to be mindful of. Coconut oil is also really bad as far as saturated fats. These are the eggs. It is now week 2 of my ophthalmology rotation, and I'm on consults all day today, so I'll touch base with y'all later and let y'all know if I learn or see anything cool. Y'all, it is the 3rd week. We're switching to a new block now, so I'm switching locations, going to the main ophthalmology building for my program. First, we have a learning session this morning on how to do the retinal exam, and after that today I'll be working in the resident clinic, and I'll have some of my own patients, which is exciting, but I hear it's busy, so wish me luck. Y'all, good afternoon. It's about 1 p.m. I'm out to grab lunch right now. The morning's been very hectic. I actually had some of my own first patients today, but some of the cases were quite complicated. But it's been a fun, exciting, high energy, busy experience so far. But I'll tell you guys more about it later, because I'm just trying to eat my food quickly and get back to seeing the rest of the patients for the day. Y'all, it is 9 p.m. and I am still here. I'm in the resident lounge. I'm about to head out and grab some dinner, but yes, today was quite the day. Good morning, y'all. It's Wednesday. It's been 2 days since I last vlogged, I think. Yesterday was fine. I did glaucoma and retina clinic, and today should be a fun day. Right now I'm heading over for lecture, and after that for the morning I'm going to be in the resident clinic. But the afternoon's where it's getting exciting. So after clinic we have an oculoplastics lecture, and then we actually have a wet lab today. So that means we get to do practice or simulate certain things. So I'm looking forward to today. Hopefully it's fun. Hopefully it's good learning. So I'll see y'all later. is Thursday. Doing finishing touches to go for work now. It's about 7:40, 7:50 or something. The suture session or wet lab that we were meant to have yesterday ended up getting moved to today. So looking forward to that this morning. I'll also be in Cornea clinic, which is where I'm about to head now. And today is also special because we have a field trip where we're going to the eye bank. From my understanding now, I'm sure I'll learn more today, but the eye bank is where they keep a lot of the eye organs that they use for transplant, specifically like the cornea. It's a great opportunity to get to go to the eye bank and kind of see another side of things and learn a little bit more about how it works. We did still have the oculoplastics lecture yesterday with our program director. It was fun. We got to know him a little bit more. It was actually my first time meeting him in person. But yeah, it's been a fun experience so far. Time to go. Hi y'all, good afternoon. I'm on Wall Street. We're heading to the eye bank now. We had our suturing session earlier today, so I'll try and take y'all to the field trip. Today's Friday, end of week 3. This morning we have grand rounds, and the topic today is something related to neuro-ophthalmology. And after grand rounds this morning, we have a session teaching us how to refract, which basically means trying to figure out what kind of glasses somebody needs. And then after that, I'm going to be in the resident clinic for the rest of the day. So hopefully it's a good Friday, y'all. Big piles of trash. Okay, y'all, I'm back from lunch. I'm waiting for one of my patients to be ready to be seen. I wanted to quickly show you guys the 4-opter, which is what we use to refract, which is what we were working on this morning. So if you wear glasses, I'm sure you've seen this before, but this is the 4-opter that we use to refract. So we have like the sphere, and then we can check like axis and cylinder. You would use this to change the cylinder, like to change the axis, you would like turn that. It's like very overly simplified, but this like closes and opens a certain eye, so that way we can look through one eye at a time. But yeah, this is the 4-opter, and this is the slit lamp. This is where patients sit. These are different lights that we use and a retinoscope. Bring this to the patient. They would usually put their chin in here, forehead against the bar, and we would like to line up the outside part of their eye, what we call the lateral canthus, with this black line. So this is where I would look through, and then if somebody else was in the room and they wanted to see what I was seeing, there's a teaching scope attached. This is the joystick. So the slit lamp's basically like a microscope. I can look here and adjust my view a bit. I have to unlock it. I can move it around. With the base of my palm, I can move this whole thing. And then I can also make finer movements with this thing here called the joystick, which can also make it go up. You can see that it's going up. And then make it go down. And then I can also make finer movements forward and back with the joystick. So that's a little bit of it. I'm trying to keep it super simple for y'all. But yes, I'm gonna check to see if my patient's ready now and see them. Apparently they're in a lot of eye pain. So hopefully we can figure out what's going on. To last day of my ophthalmology rotation, unfortunately. Today I'm doing ocular pathology in the morning, and in the afternoon I'll be in the resident clinic. I've never done any type of ocular pathology rotation or clinic before. Well, I guess it's not a clinic, it's pathology. I haven't done it, is what I'm trying to say. So I'm looking forward to getting that exposure and experience. I had some time to stop by Starbucks this morning. Got this little matcha and this little egg bacon, whatever thing. It's pretty good. So I will see y'all later. Good morning, y'all. Today's Friday. It is the last day of my first ophthalmology rotation of intern year. It's been a month. It has been a fun month, and I feel like it really flew by. Yesterday I did ocular pathology, and it was quite interesting to see under a microscope real samples of pieces of the eye and try and dissect what exactly is happening on the micro level, and then kind of relay it to different pathologies that you would see when you look at somebody's eye on the slit lamp. We were in the lab for like 4 hours or so I saw a lot of cases. I actually got to see what an amoeba, specifically acanthamoeba, would look like if it infected the eye or the cornea specifically. And it's crazy. You can actually literally look at the amoebas, like what they look like. They're actually relatively large, like much larger than bacteria, viruses. And you can just see them right there in the cornea. I'll try and find a picture if I can. We also saw some cancers in the eye. We saw a sample of orbital lymphoma. So that's like a tumor made of lymphoid cells. And it was in the orbit. So not inside this round eye, but like in the bone structures surrounding the eye. Also saw basal cell carcinoma, and how that looks under the microscope. It was interesting to see it in a real sample, because if you've been in medical school, you might know that like the palisading cells, and actually getting to see that was interesting. Remember in the video earlier I was talking about herpes virus keratitis, HSV1. I actually got to see what that would look like, and viruses themselves are too small to see under that microscope unless you did like electron microscopy, which is like getting even smaller. But you can kind of see the reaction that the surrounding cells have when they're infected by the virus. So it was interesting to kind of correlate that. And there were a lot of other interesting cases. And overall, I think I learned a lot in that session. This morning, I'm going to be in the Retina clinic, which is the back part of the eye where all the light falls on and then it transmits to the brain once it goes to the optic nerve. Retina might be fun. They see a lot of interesting cases and do injections and lasers and stuff like that. So we'll see how it goes today. And then in the afternoon, I'm going to finally be in the operating room and see whatever cases are available. I'm very excited to start seeing surgeries again. Gotta skedaddle, y'all. I have a lecture at 7:30 a.m. so it's like 6:40 now. So I'm about to go on my commute. See y'all later. What I didn't tell y'all is that this whole month I've been studying for step 3 as well. So I've been trying to do 20 questions a day, but like kind of failing at it. Ideally, I want to take my test in November or December. This rotation has actually been busier than I thought it would be, but I have had some time to study like on the subway and squeeze in what I can here and there whenever I had any downtime. So we'll see if I actually get to take it before the year ends. Y'all, coming out from Retina clinic. Today I did my first subconj injection, which is just putting in lidocaine to numb before an intravitreal injection. So that was fun. Okay, y'all, it's 8 p.m. I just got home. I am done my first ophthalmology rotation of residency. It's been a long day. So this morning I had Retina clinic, which I learned a lot in. The fellow I was working with was great. And I mentioned briefly in the elevator, I, for the first time, did this subconjunctival lidocaine to do an intravitreal injection. So it's basically an injection that goes inside the eye. And usually in Retina, oftentimes we give those medications that are anti-VEGF. VEGF is a growth factor that helps blood vessels grow. However, if there are problems in the eye where blood vessels are growing where they shouldn't or growing a little too much and is causing bleeding in the eye, especially if the blood vessels are poor quality and are friable and can just bleed, that's not good. So oftentimes retina specialists, for people who have these issues where there's abnormal blood vessel growth, they give anti-VEGF injections into the eye to help stop that process. And oftentimes that's for people who have diabetes in the back of their eye. Diabetic retinopathy is what it's called, as well as a myriad of other conditions. So before putting in that injection directly into the vitreous jelly of the eye, we need to numb the general area so it's not painful. So you inject some lidocaine, which is a numbing medication, underneath the conjunctiva, which is like the sheath surrounding the white part of the eye, or that's the bulbar conjunctiva. So I got to do that portion of the injection procedure and kind of learn how it's done a little bit better, which was fun. Then I got lunch, Five Guys, and then after I came back, I went to the operating room. I wasn't assigned to anything in particular, so I just looked at what's on the board and who's doing surgeries, and I went to cornea surgery for a patient who had corneal ulcer. So it's basically an infection of the cornea that goes a little bit deeper than just the surface of the cornea. And it was actually a really sad case. This patient had like a history of LASIK. It's a pretty young person. It looked pretty significant. There was also some inflammation in the anterior chamber of the eye, which is like between the cornea and the iris. So when you have like that buildup of white blood cells in the anterior chamber, we call it hypopyon. Put a picture of hypopyon. So yeah, we went into the operating room and tried to repair it. Not me personally, the attending and the PGY4. And also took samples to run it for bacteria and viruses. And they also injected some antibiotics into the eye. So hopefully infection and inflammation dies down a little bit, but if not, it might be needed to consider transplanting the whole cornea. So it was an interesting case to see. But yeah, that was my ophtho rotation. I hope you enjoyed the video. Feel free to comment any questions down below if I said something that didn't really make sense. I'm happy to dive deeper in it. And also remember, y'all, I am a PGY1 intern resident, so I may not know everything. So if I said something and you're an ophthalmologist and you think it's inaccurate, also comment down below. I'm ready to learn and get better every day. But overall, this was a very fun rotation. It's reaffirmed that I feel ophthalmology is where I'm supposed to be, because even when it's busy, I still feel like this is what I can happily do all day, every day, and just learn more and more about. And you get to have such a positive impact on patients, and there's so much tech and gadgets, and it's just been a fun time. I've also really enjoyed hanging out with and getting to know my co-residents. Overall, it's been a good time, so we thank God. And now I'm going to get back to internal medicine next week. Thanks for watching. Like, comment, subscribe, and share. Love y'all. Adios.